To start the discussion, I will be talking about why euthanasia should be allowed in regards to patient autonomy. The Death with Dignity National Center says that the greatest human freedom is to live and to die according to one's own desires and beliefs. As pointed out also by the Death with Dignity National Center, the circumstances of death are very personal. The definition of autonomy is the right to choose the care for oneself. According to the autonomy model that's also explained by Butts and Rich, a patient must be deemed competent in order to make these decisions regarding their care. The patient must be an adult that is considered both mentally healthy and cognitively sound. The patient who has the capacity to make their own decisions also has the right to remove or stop life support. To kind of strengthen the discussion, I'd like to bring up an example from the film, Whose Life Is It Anyways? The patient in the film suffered from an accident that left him paralyzed from the neck down. It was an irreversible health complication that left him without his normal functioning. The patient did not want to live this way and made it a point to tell the doctors that he no longer wished to live. He did not have the freedom to decide the outcome of the accident, and he did not have the freedom to choose what limitations would come as a result of the injury. The patient ultimately decided that it ruined his quality of life, and therefore that's the reason he no longer wanted to live. He was held by the physician in the hospital after he refused to release him, deeming that his desire to die in itself was depression and was reasons for him to be held back. So he met with some different psychiatric healthcare providers, and they did deem him mentally competent to make such a decision. So the end result was that they released him free to be, with the understanding that leaving the hospital would ultimately lead to his death from the complications related to the accident. And also, this brings me to the point that any competent patient has the right to refuse treatment, and they also have the right to elect not to be resuscitated in the event that they're in a life-threatening situation. In such a situation, it's generally understood that the end result will be death. Leading up to the death of the patient, they can suffer from a wide variety of clinical manifestations, such as suffocation and cardiac arrest. Just like in a DNR situation, it is also understood that the result of a terminal diagnosis is also death. When a patient receives the news that they have a terminal illness or they suffer an injury that will ruin their way of life, they generally do not feel that they want to continue with their life. And that brings me to the point that if a patient is deemed competent by the standards that are set per facilitation and by medical law and ethics, then they should also be given the right to argue that they do indeed want to end their life.
In response to autonomy against Christie's pro-autonomy for pro-euthanasia, according to the article, Autonomy-Based Arguments Against Physician-Assisted Suicide and Euthanasia, a critique, it states that physicians have obligations to promote and provide patients with autonomy, but have a priority over patients' wishes about how to end their life. In regards to the movie that Christie explained his life anyway, this specific patient was just paralyzed from the waist down. He was told that he was paralyzed, or was he paralyzed with his arms?
The neck down?
Neck down, just kidding, neck down. In regards to that, he was an artist, so that would prolong his depression of not having his hands to write. We also have to think about that as a physician and nurses, we did not collaborate to give him different options that he could do. Certain rehab. He wasn't on life-sustaining treatments. He wasn't on a vent. It was just the fact that he wanted to die because he wasn't going to do his art. So I think that's something to also look at, is that his autonomy was based on what his previous life was, and as nurses and doctors and healthcare providers, it's important for us to look at the bigger picture and provide him with certain collaboration of rehab and different options that he can do after leaving the hospital. And so I think that's another point we should look at. Historically, it is also shown that sedating a patient who is competent leads to a loss of autonomy. This brings up the question of narcotics being a loss of autonomy as well. I don't know why.
So from there, we bring up the fact that being autonomous everybody has different visions of what autonomy is and what it isn't. Some people think that autonomy is you get to decide and have, free choice of what you do, and that does include death, that does include, breaking laws, etc. And some people have this other idea of autonomy as being within, safe measures, as you get to choose the care and the treatment up until your natural death, and you don't get to decide the way you die, but you get to decide if you do have payments, you do get to decide if you're going to be intubated, who you're going to have at your bedside, where you're going to go before death. So I think that's more of the way that autonomy should be looked at in this kind of situation, because once you die, you don't have that autonomy anymore. You don't have those opinions, and you don't have those choices anymore. So basically, it's not a choice of dying or not, it's a choice of how you want to live before your natural causes take you.
Yeah, and on that point, the article I mentioned before talks about the European Association of Palliative Care, and palliative care is for those patients that are terminal that would like to be treated but not treated for their specific terminal disease. And they state that respecting autonomous decisions strengthens and restores the idea of autonomy. And this, on our side of things, kind of alludes the fact that patients are available for autonomy, but at the same time, they have to look at the bigger picture of what's going on in their life. Autonomy is to be seen for promoting and protecting one's life and one's rights, rather than allowing a patient to decide fully for their individual care, because a lot of times they don't know what their individual care actually is, and so we have to provide education for those autonomous decisions, because most patients do make decisions under not being educated about their illness or not being educated about what they can do after, for those 5 months or whatever that they have, and I think that that's important to provide for them before they make that autonomous decision.
And that also kind of moves us into our main topic on the con side of depression, and can patients make an autonomous decision when they are depressed?
Yeah. So on the topic of depression, a majority of patients with an advanced disease express suicidal ideation or request to hasten death. Those patients are suffering from unrecognized or untreated psychiatric disorders. This is stated by Dr. Breitbart. Patients that suffer from depression are 25 times more prone to having suicide. I think that a lot of these times, the patients that are depressed need to be looked at psychiatrically, just because, and even not saying that we need to medicate them with that. I mean, there's a lot of other things. There's cognitive behavioral therapy, there's interpersonal therapy, different relaxation techniques, and, like I said before, education with autonomy could also be education about what their terminal illness is. Could lead to that. Another big thing about depression is hopelessness. Hopelessness is a key variable depression and suicide. And this brings the point to, as nurses, we have the duty to provide hope for them. We have the duty to support their decisions, but also allow them to see different options for their decisions. And we need to be positive and empathetic with every approach we have with them. Instead of going into the room, mad at them because they chose to do this. We have to be empathetic and positive. But we also have to provide a sense of veracity, which could almost lead to their autonomous decision to do it. But telling them the truth is better than saying, you have this terminal illness, but you're fine. That could put them even more depressed. So I think using veracity as a key point into helping their depression is key, instead of lying to them and then having them find out earlier is going to move that depression and make their autonomous decision more uneducated. RN Hudson, in an article, points out the desire to die statements come from patients who are clinically depressed and are mostly, untreated through that. And so I think, like I said before, that, psychiatric care and review for these patients is absolutely important. As advocates for our patients, we as nurses, we need to allow advocacy for the psychiatric review for depression, because depression is a treatable condition. Whether we medicate them, they go through therapy, they have support groups, they talk to us just as healthcare professionals. But I think this could bring the point of, if a patient is clinically depressed, uneducated, and makes this autonomous decision, this could bring up a great point to provide an ethics committee. Bring together not just the doctor and the nurse, but the family, the patient, if they want to be involved, different support groups, rehabs, different stuff like that, so they can see the different points of where they're coming from. So it's not just a decision based on their depression.
I'd like to go back to your point about offering veracity to our patients. And as you kind of mentioned, this can also lead to a further hopelessness for the patient, and finding out that maybe your health is continually getting worse, or the time that you're expected to live is actually even shorter, maybe, could also, like you said, lead to further depression. But in order to make the decision, as I pointed out earlier, you have to have consent after being deemed that you're both mentally and cognitively competent to make the decision to end your life or go through with physician-assisted suicide. I'd like to point out from an article from the Journal of Law, Medicine, and Ethics, almost all jurisdictions where physician-assisted death is legal require that requesting that the individual be competent to make medical decisions at the time of assistance. So with this, even after receiving depression medications or offering them to go see a psychiatrist, they still have to be deemed mentally competent without the effects of depression to make a decision to end their life. So if indeed it is a situation where they do not feel that they want to prolong their life with the use of depression medications or pain medications, then they still have the right to make the decision to not be resuscitated or refuse end-of-life care, such as chemotherapy in a patient who is told that they have an end-stage cancer diagnosis. So in regards to that, like you said, veracity is important, but it can also lead to their further wishes to die. And if they are deemed competent and mentally capable to make such decisions, then they should be offered the right to decide when and how they pass.
Okay, so going off of that, Dr. Marcia Angel from the Truven Health Analytics Health Poll, she states that physician-assisted suicide isn't a choice between life and death, but it's a choice of the exact timing and manner of death, because the patients are already dying, the ones that most likely request to have physician-assisted suicide. They're already dying, and euthanasia and physician-assisted suicide, they are used to invoke the right to die. The decisions concerning life and death should be up to the individual who is concerned, who is dealing with a terminal illness. In many countries, suicide is morally and legally accepted. If people are allowed to commit suicide, then why should patients be without these rights when they're no longer able to perform them themselves? In medical ethics and medical law, patient autonomy is a central pivot point. Patients do have the right to refuse treatment, even if this leads to their death. Shouldn't people also have the right to determine the moment of dying if they're in a situation when it's unbearable and without the prospect of improvement? Another argument focuses on the duty of the physician to alleviate the patient's pain and suffering. If there's no other options after the patient and the doctor talk about it, as the doctor, they have the duty to fulfill the patient's wishes. They should be allowed to actively end the patient's life. The argument's not completely based on just autonomy, but also beneficence to relieve the patient's suffering. Since 2002, law gives doctors who terminate life on request an exemption from liability if they've acted in line with due care criteria and have notified death by non-natural causes to the Regional Euthanasia Review Committee. According to the criteria, a doctor must be satisfied that the patient's request is voluntary and well considered, and that the patient's suffering is really unbearable. And furthermore, the doctor should inform the patient about the situation and what all it entails, and discuss this and come to a joint conclusion that there is no other reasonable solution. And the physician must also consult one other doctor, who also must see the patient and declare in writing that all the criteria are met and that there are really no other options except to terminate in life. And that is according to Witherspoon.
And I'd also like to point out too that when you do get consent for such a decision, it's required that the doctor or healthcare provider explain the procedure in full, including the risks, benefits, possible benefits with refusal, and probability of the effects on others.
And in addition, assisting death means being compassionate towards the patient's desires and making death with dignity a real option for them. So, and according to a study by Dr. Perlman, they were specialized in geriatric care. They found that 96% of the geriatric population felt that it was better to die than to be kept alive under hopeless circumstances with impeding death.
Okay. And to go against that topic of compassion and the rules and notifying other doctors and reasoning, well, number one, I think the most important thing is the principle of non-malfeasance, and how doctors are supposed to stand up with that, and they are not supposed to do harm. They're supposed to have the patient, they need to keep their patient safe. They do everything in their power to do that, and that brings up the point of physician-assisted suicide. When you're debating between suicide and physician-assisted suicide, is the patient doing it to themselves, whereas the physician is not being non-malfeasant, and he is causing harm. He is killing that patient by either giving the drugs to the patient to take home or pushing that syringe, whatever it may be. So he is actually causing harm. So I think that's just the debate between beneficence and non-malfeasance. You want to help your patient, but I think that you can help your patient in a safe way, in a non-harming way. And going along with compassion, everyone needs compassion, especially nurses and especially physicians, but you can be compassionate without agreeing to them, your patient dying. You can be compassionate. You can get, like Carly said before, there's committees, there's people, there's chaplains, there's your family that can all have compassion for you and really be empathetic for you and talk you through it. And rather than just going to the, farthest end of the, continuum and just deciding that I want to die. You can talk to them and try to, not necessarily talk them out of it, but talk to them about why life is important for them, what treatment options are there available, and how can we work through this. So not only do you need emotional support for them, but like I said, you just really need to be compassionate in a way that, like I said before, non-malfeasance, that's not going to hurt them.
Mm-hmm. I also think that, along with what Megan says, is compassion goes hand in hand with depression as well. Most of these patients, they are clinically depressed because, they are dying, they have a terminal illness, or they don't have that support that they need. And as RNs and physicians and a healthcare team in general, we need to provide them with that compassion to help. And, so most of the time depression is not clinically treated. Most of the time it's definitely a treatable condition, but people might have it, with a family member dying, and you go through those emotions, and it is a relievable condition, if that makes sense. It doesn't have to be treated to be relieved. And I think a lot of times we forget that compassion is just that little ounce of extra medication that a patient may need in order for that, autonomous decision to be not based on depression, not based on, I want to die with dignity. I want to die like this. Why don't you die with dignity, with compassion around you, without being depressed, and with autonomous decision that you're still living your life fully, that you're still doing things that you can do, instead of, saying I'm going to, have assisted suicide on a specific date. That also does kind of bring that fact of, the depression and compassion go alongside with suffering. A lot of the times these decisions are based off of suffering, and I think that having compassion and, the depression relieved, that kind of helps that suffering, release. We don't always have to give them a sedative or a narcotic or something like that for suffering. A quick smile in the room, or, turning the patient off the side that's painful for an hour. That's also helping them in that autonomous decision, and that could go a long way than just being like, I have a specific date, this is what I want to do. And so I think a lot of times we also forget about that point and that side of the compassion.
And I want to bring up just one more quote that I forgot to say. This is from the article, The Right to Live or Die. It says, the first...
Oh my God.
Are you kidding?
Well, turn the lights on. Sorry.
Okay. So, it says, there are many arguments that have been advocated against euthanasia. The first one is that life is sacred and should be preserved. Theists believe that God gives us life and He is the only one that decides our death. Opponents also argue that when a physician takes the Hippocratic oath, his first duty is to save life, and that they contend that euthanasia actually devalues life. More importantly, they argue that assisting death to the terminally ill patient will lead to a slippery slope in which euthanasia is extended to non-terminally ill patients and for those who don't ask for it. So I think the main point in that is just that the physician taking the Hippocratic oath, and his duty is to save life, not to kill it. And, to just always think of the patient in his best interest. So.
With that, I'd like to bring up the Oregon Death with Dignity Act. In 1997, this was passed, and it was the legalization of physician-assisted suicide, but it prohibits physician-active euthanasia. So, like you said earlier, with being non-malfeasant and not killing the patient. With the physician-assisted suicide, as opposed to physician-active euthanasia is the act of administering the dose that actually kills the patient. In this situation with the Oregon's Death with Dignity Act, it's prohibited that those who are too incapacitated to take these lethal doses of medications do so on their own. So they're excluded if their illness is also not terminal, and if they lack the decision-making capacity. Also, if they're too sick to survive the appointed waiting periods. So, along with the waiting periods, it is offered that the patient wait within a certain amount of time before making the final decision to follow through with the physician-assisted suicide. But my main point is that it's not the act of actually killing the patient, but it's assisting the patient to fulfill their wishes of ending their life. And I again want to point out the definition of euthanasia according to Butts and Rich, and that's the active or passive cessation of life of the hopelessly ill, injured, or incapacitated with the goal of limiting suffering and exhibiting mercy. So also talking about having compassion for the patient that has depression. I think also if they genuinely do have the wish to end their life because of the suffering, then we also need to exhibit mercy in that sense.
That's a good point that you bring up. Also, when you think about it, in an article that we have, it brings up the point that if you provide a patient, or if a patient does commit suicide or they're active, it takes away that future freedom that they may have. It takes away those future decisions that they may want. A day from when they committed suicide or wanted to be, part of physician-assisted suicide, they could have changed their minds. It does lead to a bunch of what ifs. What if I did this? What if we waited? And I think that's a lot that we need to look at on the side of autonomy, that killing these patients and allowing them to want to be killed takes away from the fact that they still have they won't have that autonomy anymore. So that brings to the point, the fact that you're killing that autonomy from them and taking away those future decisions.
So then I'm going to talk about our last topic, and it's a reason why people actually are for euthanasia, and that's pain management. A lot of patients and family members either sign on the line that they would like for an assisted suicide or physician-assisted suicide, or some family members encourage their family members to actually go through with it because their pain is so intense and so chronic. And a good example of that would be oncology patients. They're just in so much pain. So I'm going to go into how pain kind of goes into euthanasia. So my first quote, and that's from Killing the Pain, Not the Patient. It goes like this: We are living in a time when some doctors and lawmakers think that the best solution for some patients suffering and pain is to give them lethal drugs for suicide. So my defense is to kill the pain, not the patient. Some opinion polls show support for assisted suicide when it is presented as the only relief for a dying patient in unbearable pain. But when Americans are offered an alternative, they overwhelmingly say that society should concentrate on ensuring pain control and compassionate care for such patients, not helping them take their lives. This preference is even stronger among dying patients themselves. It is found that dying patients experiencing significant pain were more opposed to suicide than the general public. So if pain can be controlled, and this does not count for everyone, thinking about euthanasia, but this accounts for a wide amount of people that actually do want to die because their pain is so unbearable. So if pain can be controlled and treated with pain management skills, medications, relaxation techniques, then why is euthanasia still relevant with these pain patients? And we actually found that once patients' pain was in control and they were not experiencing that chronic pain anymore, their decisions actually did change, and they no longer wanted the physician-assisted suicide. So, like I said before, why is euthanasia still relevant with patients that have chronic pain if doctors have access to medications? Well, the main thing is that doctors are scared and physicians are scared. So this is a quote about why doctors hesitate to give pain medication. Many doctors hesitate to give dying patients adequate pain relief because they fear that high doses of painkillers such as morphine will suppress the breathing reflex and cause death. Yet we now know that this fear is based on false assumptions and on inadequate training of physicians in pain management techniques. So what I found was that a lot of physicians are either one, scared to give higher doses of pain meds than you would normally give your average hospital patient. Look at the liability in that. There's so many lawsuits that come about, nowadays if the physician gave the wrong dose or the wrong pain medication or whatnot. So they're scared. They're scared of what could happen to their license. And not only that, but they also need more training on chronic pain management. A lot of physicians aren't really sure how to treat the pain, and some physicians, if they've never been in that position before, don't really understand how that patient is feeling. And sometimes they undermine the pain, and they might think that they're just, saying that the patient's just saying that they're at a 9 when they're really not, just because they like the feeling of the pain meds. So that's also kind of society's fault in the abuse of narcotics and the abuse of pain meds. So not only are the physicians uninformed, but as for the doctors working with euthanasia, the doctors that are for euthanasia, like in Oregon, that are actually participating in it, it's almost leads to a society where they don't try to do everything for their patient. They think, okay, well, he has terminal cancer, we'll just go with euthanasia. I'm not going to try all the palliative care measures that I should be trying, whereas a physician in Missouri was going to hopefully do everything they can because euthanasia is not an option. So again, from the article, Killing the Pain, Not the Patient, it says, once the quick and easy solution of assisted suicide is accepted into society, doctors lose the incentive to pursue more difficult but life-affirming ways of truly caring for patients close to death. The converse is also true. Prohibiting assisted suicide sets a clear limit to doctors' options so they can commit themselves to the challenges of accompanying patients through their last days. As one physician said, only because I knew that I could not and would not kill my patients was I able to enter most fully and intimately into caring for them as they lay dying. So it just brings up another point of how invested is the physician in taking care of you. And even if you're not interested in euthanasia, but it's legal, how much is that physician going to talk you into it or persuade your decision just based on how far he wants to go with you and in the dying process. So basically, the docs are kind of taking the easy way out almost with some of these cases.
In opposition to that, with using primarily pain medications to kind of ease the physical pain of the person's medical diagnosis, one of the largest reasons that people decide that they want to follow through with physician-assisted suicide is because of the effect that it has on their life and the emotional pain. And I know we discussed earlier as far as depression and getting that treated, but a lot of patients feel that they prefer not to suffer from the physical pain for such a long time when inevitably in the end it will be the disease that kills them and not their own self on their own terms. And that's something that can also be brought back to the Death with Dignity Act. The reason that a lot of these people who are given these terminal illnesses or suffer from a life-altering injury make the decision based on the fact that they do not feel that they will be happy with the end of their life. So they prefer to take it on their own terms and not let the cause of death be the disease that is causing them this emotional suffering and this physical suffering.
And I have on top of that, according to the Journal of American Osteopathic Association, even before end of life, patients with cancer, around half of them report moderate to severe pain, and up to 30% of them rate very severe pain. And an estimated 25% of the cancer patients will die with pain anyways. And so I think going along with what Christy said, emotional pain is a big aspect of end-of-life care that pain meds don't always fix. And I think that's what causes a lot of them to choose, physician-assisted suicide. And also according to the Journal of American Osteopathic Association, pain associated with the dying process is referred to as total pain, and there's 4 components of it, which are physical noxious stimuli, affect or emotional discomfort, interpersonal conflicts, and non-acceptance of one's own dying. And all of those aspects can't really be treated with pain meds. They may affect the patient's perception of pain, and the lack of doctors understanding these influences may result in less optimal pain management. And in a dying person, the pain is it's never purely physical. So things related to when and how they might eventually die influence their pain levels. And these influences include being abandoned, their appearance to their families and friends, being a burden to their family, and dying in pain alone. So these concerns all cause suffering, and they must be addressed to manage their symptoms.
Yeah, going with your point about emotional pain and other types of pain provided by, these terminal illnesses that are, causing these patients these autonomous decisions. A lot of times, we as healthcare professionals and as nurses, we forget that pain isn't just a narcotic. We can relieve pain by, repositioning a patient, putting on that specific music that they like to see. And I think that's what we forget, that a lot of that emotional pain they have, we can help fix by being that patient advocate. And we also have to remember that, yes, they're going to feel like a burden to their family, a burden to us, because we have to take care of them a lot. And with that, as their patient advocate, we need to, get together. We're not just taking care of the patient, we're taking care of the patient's family. we have resources available to us in the hospital and outside the hospital that can bring, adequate relief to that pain for both the family and the patient. And I think that that's a lot of the time people think pain management and all they think is, oh, your pain's a 5, let's get you morphine for that. But we also have to remember that that pain isn't, like you said, it's emotional, it's noxious, it's not just physical. And I think that applying our, as a registered nurse, applying our education to them about different ways to do that, whether it's soaking your feet and, having a foot massage or something like that. Like, that's going to relieve a lot more than just physical pain for that patient. And that's what we have to focus on instead of just saying, okay, well, your pain's emotional. We can't fix that with morphine. Your autonomous decision is correct. I think that that's kind of not looked at as well as different stuff like the noxious stimuli too.
Okay, well, that is our debate. Thank you.
Thanks.
Is there